Welcome and thank you for joining us today. My name is Claudia Alvarez. I'm a program associate with the National Center on Substance Abuse and Child Welfare. I'd like to welcome you to the webinar, Better Together, Developing a Coordinated Response for Families Affected by Substance Use Disorders. I will now turn it over to Catherine Luby, Child Welfare Program Specialist with the Children's Bureau, for some opening remarks.
Thank you so much, Claudia. A big thank you to Han and the staff of the National Center and to the National Center's FDO, Elaine Stett, for this opportunity, and for all of you who are joining us on the line. I know it's been a very busy day. Some of you have just come off another call for CJA and a very busy time in general of the year for CJA. The Children's Bureau is very excited to be hosting this webinar with the National Center on Substance Abuse and Child Welfare. The Center on Substance Abuse and Child Welfare is some work that we're really proud of here at the Children's Bureau, and it's an example of true collaborative efforts at the federal level. It grew out of interest between two agencies who acknowledge the intersection of substance abuse and child welfare and the critical need to coordinate efforts in this intersection and to align thinking. The center is jointly funded by the Substance Abuse and Mental Health Services Administration, SAMHSA's Center for Substance Abuse Treatment, and ACYF, the Administration on Children, Youth, and Families Children's Bureau. The National Center seeks to improve systems and practice for families with substance use disorders who are involved in the child welfare and family judicial systems by assisting local, state, and tribal agencies. The National Center provides a continuum of technical assistance services that include resource referral, long-term consultation with sites, product review and development, and dissemination of best practices through conference presentations and web-based trainings. This particular webinar for CJA was put together in response to a number of questions we got at the Children's Bureau from CJA leads in states noting an increased awareness of this intersection point between child welfare and substance use and the desire to learn more about the issue and the importance and opportunities for collaboration in the area. As you're aware, CJA is a very targeted program looking at the front end and investigative piece of child welfare. What we know, but we'll hear more about today on this webinar, is there are various points in the life of a case that substance abuse may impact. Center staff have done a wonderful job pulling together a whole lot of information on this issue of substance use, the impact it has on families and children, what we know works in addressing it, and the importance and opportunity for collaboration. We hope this webinar will increase your understanding of the National Center and their work as a support, the issue of substance use, and that it will serve as the beginning of a conversation for this group around how CJA may support efforts in this area. Our speaker today, Han Dow, serves as the National Center on Substance Abuse and Child Welfare's Technical Assistance Manager. In this role, she oversees the coordination of and response to technical assistance requests received by the National Center through its various programs. As part of her role at the National Center, Ms. Dow works with local and state-level jurisdictions who are seeking to develop collaborative practice to improve outcomes for families affected by substance use disorders. Prior to joining the National Center, Ms. Dow served as an emergency response social worker within the Los Angeles County, California Department of Children and Family Services. We are so happy to have her with us today, and we look forward to her presentation.
Thank you, Catherine, for those opening remarks. I really wanted to take the time to thank you today, for those of you in the audience, for joining today's webinar and for the opportunity to discuss the role that substance use has on child abuse and neglect. And so you may have heard Catherine mention that prior to joining the National Center, I worked as an emergency response or investigative social worker with the LA County Department of Children and Family Services. So the issues that we're going to discuss today I really hold near and dear to my heart. So it looks like we have about 33 states and Puerto Rico represented today. We really hope that you find this webinar informative and useful to your role in the Children's Justice Act program, as well as in the additional roles that you're probably juggling. So from today's presentation, we really hope that you get number one, an understanding of how collaborative practice can improve outcomes for families impacted by substance use disorders. And really, what does that mean for the focus of your work as a CJA grantee at the front end of the child welfare services spectrum? Number two, we're going to explore strategies and considerations in working with families affected by substance use disorders. Again, what does that look like during the emergency response or investigative phase of child welfare services? We do have a lot of content before we get to the third item of the how-tos of collaborative practice. So I'm really going to try to close out the presentation with a little bit of information on the how-to of collaborative practice. lastly, in recognition of today's environment and climate, you really cannot have a conversation on and about substance use disorders and their treatment without addressing the opioids issue. So throughout the presentation, you'll see how I've tried to integrate that within some of the content that we'll be discussing. So as you can tell, the agenda is pretty jam-packed and pretty ambitious, so let's go ahead and get started. We're going to go ahead and start with some data and statistics to help set the stage, to provide some context to get an understanding as to potentially how many children and families are affected by parental substance use disorders. So about 8.3 million children are estimated to be living with a parent who is dependent on alcohol or drugs. So to make that a little bit more real for you, that translates to about 11% of the country's children, or this paints a much more, I think, impressive picture that translates to about 3 children in a classroom of 30. So this really represents the universe, or the broad number of children who may be affected by parental substance use, but it really doesn't tell you the actual numbers of children who are affected by parental substance use who actually come to the attention of child welfare services. So let's try to drill down to that a little bit. So the first question that I'm going to pose to you today is, in your state, what do you estimate to be the prevalence of child welfare cases that are affected by substance use disorders? We're going to go ahead and launch this polling question. You should see a dialog box populate on your screen that will allow you to respond to this question. Do you think that the cases in your state or jurisdiction, about maybe 0 to 25% are affected? Is it more like 25 to 50, or perhaps it's the majority, 50 to 75, or 75 to 100%? Feel free to also indicate if you're unsure. Maybe you feel uncomfortable answering this question because you don't have the data. That's okay. I want you to answer based on your experience in working with child welfare families. Okay, so it looks like the majority of you agree that the majority of child welfare cases are affected by parental substance use disorders, about 50 to 75%, and the second highest response rate was in the 75 to 100 response rate. So this is really in line with what we hear from sites, is that the majority of child welfare cases are affected by parental substance use disorders. Thank you, Claudia. So then let's take a look at what the actual data tells us. So the data reported to the Adoption and Foster Care Analysis and Reporting System, or AFCARS, indicates that of all children removed in 2013, 31% of those cases had a risk factor or involved parental substance use. So you might be experiencing what many the same feedback that we often get when we share this slide. Now, the 31% doesn't really ring true. You know, particularly since the majority of you responded that at least half of cases are affected by parental substance use disorders. What's even more interesting is if you look at the data that's presented here across states, the range across states also varies greatly. You can see some states indicate that under 10%, maybe 5% of the cases are affected, whereas other states indicate that almost 65% of the cases are affected. So this slide shows the trends in opioid use. You can see, well, I think the addition of this particular data set may have interrupted the flow of the conversation a little bit, so it might feel a little bit choppy when we address some of the opioid issues. So I do apologize for that. I do recognize that it may have taken away from the flow of the presentation. So if you'll just bear with us, I think this is one of the first presentations that we're doing in which we're trying to integrate some of the opioid-related issues with some of our other content areas. So again, this slide is really showing that across the board in the number of initiates are those who are new to the use of heroin. Across the board, in terms of the numbers of people who are dependent on heroin, and across the board in terms of the number of people who experience overdose deaths related to opioid use, there's an increase in all three of those categories. So before I move forward and really get into some of the data on this slide, I'm going to give a brief definition as to what I mean when I say opioid, opioid use disorders, and the opioid use-related issues. So opioids are defined as heroin and some of the prescription pain medications. So that's really what we're talking about when we say opioid use and so forth. So the two data points that really stand out to me on this data slide is, number one, the 50% increase of persons 12 or older who are dependent on heroin. So it's not just that number, that 50% that jumps out at me. It's concerning because of the potential impact of substance use on the developing brain and all of those cognitive capacities of somebody who is still developing in whether a pre-adolescent or an adolescent. The other thing that really jumps out at me is the over 500% increase among women in opioid pain reliever overdose deaths since 1999. So that's not a typo. It's not supposed to say 5%. It's not supposed to say 50%. It says 500%. So, of course, that number is staggering and quite concerning. The other reason this point jumps out at me is because a large number of women affected by opioid use disorders as well as substance use disorders are women of childbearing age. So, of course, that becomes concerning because of the potential impact that may have on the infant. So that brings us to the next slide, the issue of neonatal abstinence syndrome. So because that is a mouthful, I'm going to reference the syndrome as NES from this point forward. So I'm just going to give a brief overview of what NAS is to provide a little bit of context. And in essence, this slide is kind of saying the same thing as in the previous slide in that there has been an increase in the number of infants born with neonatal abstinence syndrome, or NAS. So generally, NAS is composed of a host of symptoms that include blotchy skin, difficulty with sleeping and eating, trembling, and irritability. And NAS can affect babies who are exposed prenatally to opioid use. So there's a huge variance in how this disorder manifests. So, for example, the symptoms can begin within 1 to 3 days after birth or even take as long as 5 to 10 days to appear. It occurs with notable variability. The studies show that of infants who are prenatally exposed to opioids, the range is about half to 94% of these babies actually develop some sort of NAS symptoms. So all of this variation is related to a lot of different factors. These include timing of the last exposure, the type of substance the baby was exposed to, exposure to multiple substances if the mom was a polysubstance user, and some of the lifestyle issues related to the mother, including potentially risky behavior related to the substance use, as well as whether prenatal care was accessed. The treatment of NAS includes both medication-based and non-medication-based treatment. Non-medication-based treatments include having the mother and infant room together, swaddling the baby, and provision of other comforting and soothing techniques to soothe the baby's experience of some of those NAS symptoms. So this might look like providing a calm, dark environment for the baby. About half of babies who experience NAS require some type of medication to better control and manage those symptoms. The reality is that the goal of both types of treatment, both medication-based and non-medication-based, are to manage the NAS symptoms to promote that bonding attachment between the mother and the child. So later in the presentation, we will again address opioid dependence and more fully its impact on child welfare practice. So back to the data. Again, I do recognize that inserting some of those data points on the opioid issues is interrupting the flow of the conversation a little bit. So we welcome that feedback so we can figure out how to better integrate those talking points into this presentation. So the previous slides provided a picture of potentially how many children are impacted by substance use disorders. However, that picture probably feels incomplete since the range between states is so diverse. The currently available studies also paint the same picture. The studies have found a prevalence rate from about 5% all the way to 90%. So why don't we really understand how many families and children are affected by substance use disorders? Some of the issues related to the kind of lack of understanding of how many children that are affected by substance use disorder include the issue of screening. How is substance use identified? Is it solely when the allegation in the child abuse and neglect report has an allegation involving parental substance use? Or is there some kind of universal screening protocol to potentially identify the universe of families who are affected by substance use disorders? So related to the issue of screening, how is that defined? Is it really only defined as those parents with a diagnosed substance use disorder, or does that universe also include parents who are using substances that are not diagnosed with a substance use disorder? So the issue of points in time is also related to the issue of screening. So again, when is the substance use identified? Is it really only as part of the initial child abuse and neglect report, or is it identified during the case of the emergency response? As many of you in the audience may well know, you might get an initial child abuse and neglect report that has a primary allegation of physical abuse or neglect. And when you go out there and respond and do an assessment of the family, you realize, hey, there's a couple of other issues that this family is experiencing, and potentially that can include parental substance use. So kind of the same scenario can happen in a case that has already been promoted for ongoing services and perhaps is receiving family maintenance services, and for some reason the parental substance use factors surface much later in the case. So the last issue are data systems. What is the capacity of the current child welfare data systems to track many of the issues? At a minimum, is there kind of a checkbox to say, yes, this case has a substance use related risk factor? And at a minimum, if that box is there, what is the capacity to track any of these other issues? So you might be thinking to yourself, well, why is it important to understand the numbers? We all kind of already agreed that the majority of cases involve some type of parental substance use. Well, I would pose back to you, how can we really ensure the safety of children when we really can't show how many children are being affected, and it really boils down to a resource issue? It becomes really difficult to allocate and ensure the appropriate resources if you can't show how many children are being affected. I mean, just from what you responded today, you in the audience today feel that at least 50%, if not more, of cases are affected by parental substance use, but yet the data systems are showing an average of 31%. So if you're going to make the case that more resources are needed for these families, you really need to understand what is the total number of families and children in need of services. So now we'll move on to a brief discussion on what has been accomplished to address the issue. The implementation of ASFA, or the Adoption and Safe Families Act in 1997, placed a renewed emphasis on achieving permanency for children in the child welfare system. Of course, one of those outcomes include a renewed interest in finding ways to work with families affected by substance use disorders. Following the passage of ASFA, 5 national reports addressing the issue were developed. In response to those reports and in ASFA, in 1999, the report Blending Perspectives and Building Common Ground was introduced and introduced 5 national goals, the ones you see on the screen. Number 1, building collaborative relationships. Number 2, ensuring timely access to treatment services. Number 3, improving our ability to engage and retain parents in care and support in ongoing services. Enhancing children's services and filling information gaps. So the focus of today's presentation will really be on the first 2 goals on this slide, the importance of building collaborative relationships, and number 2, ensuring timely access to comprehensive treatment services. So those 5 goals were really developed to address many of the identified barriers, and barriers that you probably experience on a day-to-day basis in working with families affected by substance use disorders. So certainly there are variations in the child welfare and dependency court response in regards to decisions on case opening, child removal, reunification, termination of parental rights. There are certainly differences in values and perceptions of the primary client. Generally, child welfare tends to see the child as a primary client, where substance abuse treatment tends to see the parent as a primary client. So how do you bridge that difference so that a coordinated response can be developed to improve the family's overall outcomes? What we often hear from sites are that there are knowledge and practice gaps in screening and assessment, or in the identification of substance use disorders. And then more fully, what does that substance use mean for child safety and risk? So over the past 15 years, the federal government and some private foundations have provided funds to test in essence, test programs that respond to this population of families. So this map shows the various sites that we have either worked with or are currently working with to work with families affected by substance use disorders. They differ in the strategies that they're implementing, but the one consistent factor among all of these sites is that they are implementing some sort of collaborative practice to improve outcomes for families affected by substance use disorders. So through work with all of these sites, 5 outcomes really began to jump out at us. So the families did better in terms of recovery, in terms of the parents' recovery from substance abuse treatment. More children were staying in the home. More families were experiencing reunification. Less families were experiencing recidivism and reentry to out-of-home care. So the more child welfare-oriented outcomes of remain at home and reunification may feel very familiar and resonate with you as they align with the operational definitions in the CFSR or the Children and Family Services Review. So the reason I wanted to share this slide is because the importance of shared outcomes is critical, as it really moves the focus away from a singular system and its primary identified client to a more comprehensive lens that involves multiple systems and really identifies the family unit as the primary client. It's often the role of child welfare to determine whether substance use is a factor in a case or allegation and whether that substance use poses a risk or safety issue to the child. Clearly, not every child who lives in a family affected by substance use is abused or neglected. The rest of this presentation will discuss considerations for making decisions on risk and safety for these families. Secondly, I'm really hoping to highlight the role of screening and assessment in opening the door to substance use treatment. Numerous studies clearly demonstrate that early and timely access to treatment results in positive treatment outcomes. And the only way that can be done is through collaborative practice. So first, a brief look at terms and conditions to clarify what we are talking about today, particularly as the terms screen and assessment are commonly used in both child welfare and substance use treatment practice, but they really tend to mean different things for each system. So a screen for a substance use disorder really tries to identify at a very basic level, is substance use a factor in the case? Taken in combination with the observations made by the investigating social worker, it can help determine whether a more in-depth substance abuse assessment is necessary. So a screening tool generally results in a yes or a no. It's composed of a standardized set of questions to determine the risk or probability of an issue. Ideally, it should be brief and easy to administer, whether that's done verbally or written. Of course, a lot of the work at the front end of child welfare takes place in the field, in the parent's home. So ideally, the screens used for this particular point of child welfare practice should probably be done orally versus written. Again, ideally, it can be administered by a broad range of people, including those with little clinical experience. So because the issue of how to best identify substance use disorders is one of those most often requested technical assistance requests that we got at the National Center, we developed this publication, Screening and Assessment for Family Engagement and Recovery. And I know it's really teeny, teeny, tiny, and you can't really see it. But we've included the link on the bottom of the slide. And by clicking that link, it'll take you directly to that publication. And it's SAFER for shorthand. So SAFER does a lot of things, but the reason I'm highlighting it on this slide is because we've included an appendix of screening tools that can be used in child welfare practice. Often, drug testing is used as a screen to determine the existence of a substance use issue in child welfare practice. What is often also true, it is also the most frequently and sole determining factor in decisions made on child removal, reunification, termination of parental rights, and in measuring parent practice. So again, because this happens to be another top requested technical assistance request, we've developed this publication, Drug Testing and Child Welfare, Practice and Policy Considerations. So while drug testing will certainly give you useful information in terms of whether an individual or parent has used or tested substance within a detectable time frame, it cannot answer a lot of those questions that you need to answer to make a determination on child safety and risk. So the results of a drug test will not tell you whether the parent is experiencing a substance use disorder. And if a disorder exists, it won't tell you the severity of the substance use disorder and or what are the treatment needs of the parent. It certainly cannot tell you whether the child is safe and what the parenting capacities of the parent are. And many of these issues are outlined in the drug testing publication. So in contrast to screening tools, assessments are more involved and may require administration by trained clinicians or other professionals. So in the context of assessing for substance use disorders, its primary purpose is to determine the nature and extent of the substance use issue. Again, to determine whether a substance use disorder exists and what is the level of care necessary to inform the treatment plan. It entails a process of information gathering to diagnose and determine treatment needs, and generally encompasses a multidimensional assessment. And I like to liken the multidimensional assessment to what we often refer to in social work practice as a biopsychosocial assessment. An assessment that looks at the comprehensive needs of the family. So in summary, screens are generally short tools used to determine whether a substance use issue exists. In the context of child welfare practice, a screen can be implemented to determine whether substance use is a factor in the case. The results of the screen in combination with the observations, collateral contacts, etc., being collected by the investigating social worker can be used to determine whether a more in-depth substance use assessment is necessary. So I'm going to ask you to apply your critical thinking skills for a little bit. I'm going to ask you to apply the concept of screening and assessment for substance use disorders as previously discussed to the idea of the comprehensive assessment that needs to happen to determine whether there's a child risk and safety, as well as what are the family's overall needs. So in this context, the assessment really seeks to examine a variety of issues to determine the family's needs and strengths. The idea of this comprehensive assessment can be thought of as an ongoing process that happens on a continuum to determine, number one, the presence and immediacy. So is substance use present in the case? Number two, what is the immediacy of the substance use issue? What should be the immediacy of the response? The second component of the continuum is what is the nature and extent of the issue, and this is where you see the substance use assessment come in. It will help you determine what is does a disorder exist and what are the treatment needs. The last component in this comprehensive assessment is the development and ongoing monitoring of, and this is in quotations, the response. And often the response in child welfare involves the decision on whether out-of-home placement is necessary, whether a safety plan is the best response, and as you move forward, if the case is promoted, what the case plan should look like. And then in the treatment field, what that looks like is the development of a treatment plan. So when it comes to collaborative practice, the question becomes, how do you sync up those two different things? How do you sync up the child welfare response with the treatment response? How do you think of those two case plans? And that's an important question because of the potentially competing and conflicting timelines that may be set forth in some of those case and treatment plans. So I'm going to ask you to hold on to the three rectangles in the bottom left-hand corner of the screen. It really speaks to the need to assess for the family's entire needs. So what does that mean? It means needing to identify and understand and respond to not just the parent's substance abuse treatment needs, but what are some of the other needs and some of the strengths and protective capacities available to them. It also means understanding the child's needs and strengths. So when moving forward, I wanted to spend some time on describing what substance use disorders are and what the treatment looks like. The general definition of a substance use disorder is that it is a chronic, relapsing brain disease that is characterized by compulsive drug seeking and use despite harmful circumstances. We don't have the time to go through the rest of the points on this slide, especially since we will be going through them much more fully in the subsequent slides. But before we move forward, I think the three primary takeaways I'm hoping you get from these slides and from the rest of the slides on substance use disorders are that, number one, substance use disorders are brain disorders. They are also chronic conditions, and treatment really works. So substance use disorders exist on a continuum ranging from experimentation and use to a full-blown diagnosis. And the diagnosis of substance use disorders ranges from mild, moderate, and severe. And the differences in diagnoses are really based on the number of symptoms or criteria related to the substance use experienced by the individual. And the DSM-5 nicely lays out what those symptoms and criteria look like. So in a nutshell, the criteria are organized by four primary areas: impaired control, social impairment, risky use, and pharmacological criteria that speak to some of the physiological impacts of substance use, including tolerance and withdrawal. So to help portray and perhaps to help understand a little bit more what I mean when I say that substance use disorders are a brain disorder, I'm going to take you on a short exercise. Think of a pleasant experience. Maybe it's a romantic evening, a relaxing vacation, playing with a child, or if you're me, maybe that means shopping. Think of the pleasant feelings and experiences you associate with those experiences. So those feelings of pleasure are driven by dopamine, a chemical that is secreted into the brain. So dependence on substances do the same thing, only at a much more intensive level. So when the brain is exposed to substances on an ongoing and frequent basis, essentially the brain loses its natural ability for pleasure and requires increased stimulation at an escalated rate from substances. And this really speaks to the issue of tolerance laid out in the previous slide on the DSM-5. And of course, this strongly reinforces the behavior of drug use. So in addition to the functions regulated by dopamine, substance use also has impact on other areas of cognitive functioning, including judgment, decision-making, learning and memory, and behavior control. So truly understanding and accepting substance use disorders as brain disorders requires a new way of thinking in terms of how substance use disorders are treated. They really no longer can be simply thought of as a moral failing or character flaw. So following the same line of thought from the previous slide, substance use disorders are not only brain disorders, they are chronic conditions. Again, this requires movement away from the notion that substance use disorders are moral flaws or failings. So understanding substance use disorders as chronic conditions really accepts the idea that the treatment for such disorders should target deeply ingrained behaviors and lifestyles, such as in the treatment of other chronic conditions such as diabetes or heart disease. Since substance use disorders are chronic conditions, similar to the other chronic conditions of diabetes, hypertension, and asthma, the relapse rate is very similar. So understanding this requires an understanding that if a parent or individual relapses to substance use, it does not mean it's a failure. It does not mean that treatment doesn't work. It simply means that the treatment plan needs to be adjusted. The good news is that treatment works. So I think the key point of this slide is the goal of treatment isn't limited to only stopping drug abuse and drug use. The goal of treatment should really be to return people to productive functioning across multiple domains in their lives, including in the family, in the workplace, and the community. Of course, individual treatment outcomes are dependent on a host of factors, including the nature and extent of the substance use, as well as any other co-occurring issues and factors that they may be experiencing, and whether treatment responds to any of those other additional issues. Another important component to determine treatment quality and outcomes is the match and quality of the treatment. Because there are so many dimensions to substance use disorders and treatment, the National Institute on Drug Abuse has developed 13 principles of effective drug addiction treatment. I've highlighted the key principles that we're hoping to get across in today's presentation. Many of which we may have already addressed. So number one, addiction is a complex but treatable disease that affects both brain functioning and behavior. Number three, treatment needs to be readily available. Number four, effective treatment attends to multiple needs of the individual. 7, medications are an important element of treatment for many patients, especially when done in combination with counseling and other behavioral therapies. Number 8, an individual's treatment and services plan must be continually assessed and modified. So we're going to move a little bit to some of the medication-assisted treatment or the treatment of opioid dependence slides here. So in a nutshell, what this table is trying to provide information on is on the 4 currently used medications used for the treatment of opioid dependence. So generally how these medications tend to work is that they act as blockades to the neurotransmitters that respond to the opioids. They differ in some sense in that the level of blockade, or, well, that doesn't sound right. What I'm trying to say is that some are full blockades, whereas others act as partial blockades. Some other ways that they differ is that not all of them can be used with pregnant women. And of course, there's differences in access between some of these medications, because some of the medications can only be prescribed by a medical doctor, some can be prescribed at an opioid treatment facility. So the key takeaways from that table are that each medication varies in its ability to prevent or reduce withdrawal symptoms and or prevent or reduce drug craving. So again, those two are related to how these medications work. The key takeaway from this slide is that medical doctors determine the appropriate type of medication, dosage, and duration based on each person's biological makeup, addiction history and severity, and life circumstances and need. So lots of studies show that medication-assisted treatment works, particularly when done right. So what do I mean when I say when it's done right? If it's done in combination or as part of a comprehensive treatment program, such as behavioral counseling, group counseling, peer support, and so forth, medication-assisted treatment has been shown to increase retention in treatment because longer stay in treatment result in better outcomes, decrease illicit opioid use, decrease criminal activities, and decrease drug-related HIV risk behaviors. So the American Society of Addiction Medicine, or ASAMS, has developed levels of care for substance use treatment. To help determine the level of care appropriate for each individual, ASAMS has also developed the Patient Placement Criteria, or PPC. So I've really only included this slide and this information to give you an idea of the range of what substance use treatment looks like. And again, these are some of the levels of care that is determined by the in-depth substance use assessment. And this slide basically provides the same information as the previous slide, but again, I've included it to give you a much more detailed awareness and understanding of what treatment looks like within each treatment level. So before we wrap up this section on understanding substance use disorders, I just wanted to again highlight the key points that substance use disorders are brain diseases, they are chronic conditions, and treatment works. But what does that mean for your child welfare practice? The impact of substance use disorders on cognitive functioning can really impact an individual's memory. For instance, you might give a referral for a parenting class to a parent as part of their ongoing case, but perhaps the parent didn't remember because of their loss of memory from substance use. So this can be interpreted on the parent's part as lack of engagement or noncompliance with the case plan. However, understanding the impact of substance use and disorders on brain functioning allows for potentially a different perspective on why the parent may not have followed up on the referral. The idea of relapse as an expected occurrence allows for adjustments in the case plan, such as in the visitation plan. Collaborative practice can really help facilitate this through identification of relapse triggers and development of relapse prevention plans. I think for the most part, we're all aware and in agreement that involvement with child welfare can be pretty stressful and trigger relapse for families. For instance, continuous changes in assigned staff without notice can feel really frustrating. And of course, reunification is a much anticipated event, but it can also be a high point of stress and potentially trigger relapse for some parents. So it's really understanding and anticipating and developing a comprehensive response to some of these issues, I think, is what we're trying to get across. So we spent a lot of time discussing screening, assessment, and trying to understand the basics of substance use disorders and their treatment. We'll now turn our attention on trying to tie together those pieces to explore and understand risk, safety, and service plan development for families affected by substance use. Clearly, not every child who lives in a family affected by substance use disorders is abused or neglected. Depending on the nature of the substance use in the family, there are several situations that put children at risk, including whether it involves production or manufacturing of substances, involvement in drug trafficking, mother uses while pregnant, parent lacks the ability to respond to the child's needs, driving under the influence, neglect of the child's needs, resulting in the children left unsupervised, and or inconsistent behavior on the part of the parent as related to the substance use. So there really is a need to know and understand the different responses required for each different situation. A comprehensive assessment of safety, risk, and need can help inform this response. So the opioid-related issues really highlight the variation in circumstances in substance use-related cases that come to the attention of child welfare. So this diagram shows 5 potential situations or scenarios that involve opioid use and could potentially result in a baby being born with NAS. So you can have a parent who experiences chronic pain and is being prescribed medications to manage that chronic pain. You can have a parent who is being legitimately prescribed medications but may be misusing. You can have a parent who is in recovery from opioid dependence and is receiving medication-assisted treatment to treat that opioid dependence. You can have a parent who is actively abusing or dependent on heroin. You can have a parent who is misusing prescription medications that have not been prescribed to them. I think something that's missing here is that you can have a parent who is legitimately using prescription medication. So again, all of these different situations and scenarios can come to the attention to child welfare as a potential child abuse and neglect case, and it can result in potentially a baby being born with NAS. So I wanted to share these different scenarios to really highlight that there's a need for understanding, really a need to understand what these different scenarios mean for child safety and risk and overall family well-being. So the next set of slides represent an exploration of determining safety, risk, and need in the context of parental substance use. We're going to explore 3 concepts: safety, risk, and need as part of this discussion. Of course, since the majority of our audience is coming from the child welfare system, these concepts probably feel really familiar to you, particularly if you are working with a jurisdiction that has implemented SDM or structured decision making. The concept of safety refers to the current conditions within the family or the home which pose an immediate threat of danger to the child, and that's key. What is the immediacy of the threat? It also involves an identification and exploration of the protective capacities that may or may not exist within the home to mitigate or manage the threats of danger. So how this plays out in child welfare practice, particularly at the front end, is that it helps determine whether a response or investigation is necessary to receive child abuse and neglect report. And number 2, if a response is determined necessary, what is the response time assigned to the investigation? The concept of safety is also central to the investigative work or emergency response. The worker has to make a decision on number 1, do immediate threats exist to the child? And number 2, if those threats do exist, do protective factors exist, and do those protective factors sufficient to prevent out-of-home care? The concept of risk refers to the likelihood that maltreatment will occur or reoccur in the future. Again, this is also central to the task of front-end child welfare services. The risk assessment is often used to determine whether the allegation or report should be promoted for ongoing services and or potentially referred out to community-based services or to an alternative response type program. So the concept of need is distinct from safety and risk as it speaks to the service priorities, including any parental deficits It is often what drives the development of the case plan. It happens much later in the child welfare case, generally after kind of the emergency response phase has been completed. Of course, all of the information that is gathered as part of the emergency response should also be included in the development of the case plan. The profile that is developed from an assessment of the safety, risk, and need of each family can really inform the development of a comprehensive and individualized case plan for each family. Again, safety decision-making confronts the question of whether or not children can remain safely in the home and whether protective capacities exist to mitigate some of the threats to safety. Specifically for families affected by parental substance use, there is a need to identify correctly the drug-related safety threats and to evaluate the capacity of parents to protect children. This really requires an understanding of the predictive risk factors that can inform the child welfare response. And again, the child welfare response can range from the development of a safety plan, a decision to remove the child from parental care, and or a referral to community services. So typically, in our work with sites, what we often see is that there is either an inconsistent response to allegations involving substance use instead of a differential response. So when I say differential response, I'm not referring to alternative response or differential response programs. Instead, I'm using the term differential in the context of the need to develop and respond to each family that presents with a substance use disorder based on the needs presented by the family. So sometimes we see a one-size-fits-all approach. So this can range from an automatic decision to remove the child from parental care for all cases involving prenatal exposure without an understanding or examination of additional factors, such as whether the exposure is related to legitimate use of prescription meds or perhaps the parent is undergoing medication-assisted treatment for the treatment of opioid dependence, or even of the potential protective capacity and or factors available to the family. At the other end of the spectrum, a one-size approach can include, an automatic decision to refer alcohol or marijuana-related allegations, that come into the hotline to alternative response or to community services, or even a decision to not respond to that particular referral or report without an understanding of the risk, without an understanding or questioning or assessment of what are some of the potential risk and safety factors that exist for the family. I'm going to do a brief pause and do a time check. About how much time do we have left? Okay, so we only have about 12 minutes left, and we do have a lot of, quite a few slides to go through, and I do apologize for that. Are we scheduled until 11 Pacific Standard or 11:30? 11:30. But half an hour. Oh, okay. Thank you, Claudia, for that reminder. So we initially scheduled about 30 minutes for discussion. Have there been any questions that came into the question log? So if we're in agreement, I think we might spill over a little bit into the time allocated for the discussion piece. Okay, so if you have any feedback or questions or discussion points at this point, feel free to enter that into your questions log, and we'll make sure to answer those questions at the end of the presentation. Okay, so the next set of slides address the next set of slides discuss some of the factors that have been identified as risk factors for increased child maltreatment, and they're grouped by the child risk factors, the parent risk factors, and more of the family level risk factors. Some of the child factors related to increased risk for child maltreatment include the age of the child. So younger children, those under 6, and especially babies, those under 1, are at the highest risk for child maltreatment. The needs of the child may put him or her at risk, particularly for a child who may have special needs, whether that means some kind of behavioral needs, maybe they have a medical condition. So if you put the combination of a high needs or a special needs child with a parent who kind of lacks the coping skill necessary to respond to the needs of this child, you'll see that it's a situation of concern. And of course, what we often see in working with parents with substance use disorders is that there is a lack of coping skills to kind of deal with the stressors that he or she may be faced with. Some of the parent factors that increase risk for child maltreatment include, of course, substance abuse and mental health issues. They are the most frequent risk factors for maltreatment. Again, the issue of age. The younger the parent, the higher risk of child maltreatment. Parents that have a history of foster care or abusive child are also at a higher risk for potentially maltreating their children. So what you really see emerging from this slide is a profile that speaks to the intergenerational nature of substance use disorders and involvement in child welfare, and how that can manifest in re-traumatization and what that means for the next generations of our children. So some of the parenting and family factors that increase risk include single-family households as well as larger family size. So of course, I think we all understand potentially why those types of family situations may be faced with additional stressors. A family history of interpersonal violence is really correlated with the increased risk of physical abuse. Issues affecting parental ability include a history of depression, a high level of stress, and poor coping mechanisms. And of course, you'll see that many of these same risk factors are also what we see in working with individuals affected by substance use disorders, particularly the lack of coping skills. Okay, so but the good news is that there has been lots of work done on protective factors and child maltreatment. The resource that I'm highlighting here on this slide, I really can't read it because my screen is tiny. Claudia, can you read that for me?
Protective factors approaches in child welfare. Protective factors approaches to child welfare.
Thank you, Claudia. So this brief was developed by the Children's Bureau and the Child Welfare Information Gateway, and it really examined the protective factors available to prevent or mitigate some of the child maltreatment factors. It examined 3 different approaches to protective factors to identify similarities to develop a practice model. So it resulted in the development of 3 categories of protective factors. So the categories are the individual level protective factors, including some of the ability to self-regulate and some of the problem-solving skills. At the relationship level, this includes some of the parenting capacities, and at the community level, this includes a positive school environment, a positive community environment, and economic opportunities. So I'm going to take a break again and ask if you have any questions to please populate those into your questions box, and we'll make sure that we answer them as best as we can at the end of the presentation. Okay, this slide brings us back to the point I asked you to hold on to earlier, the concept of identifying the needs of the entire family. Identification and understanding the interplay of the needs of the entire family really requires a collaborative approach between all of the systems. Maybe one of the most difficult tasks of this collaborative is to match the child welfare intervention with the treatment needs of the parent. So the way this slide depicts the child welfare response against the spectrum of substance use disorders is not really accurate when you look at the totality of the family's needs. For instance, you can have a case involving driving under the influence that involves children being transported in the car, and the response can be an automatic decision to remove children from parental care. However, without a full assessment, there is really not an understanding of whether the parent has a substance use disorder and what that impact is on child's risk and safety, and the level of treatment needed, and whether protective capacities exist in the home to allow the child to remain in parental care. You may have a parent who is assessed to have a severe substance use disorder and placed in intensive outpatient treatment, and protective factors are found to be in the home, so perhaps the child does not have to be placed in out-of-home care. Or the parent with a severe substance use disorder, in the absence of protective factors, may require placement of the child in out-of-home care. So this slide is trying to summarize and reiterate the points that I hope I was trying to get across in the previous slide. So generally, to be most effective, case plans, treatment plans, the collaborative response, etc., really should be specifically tailored to the risk and need profile of each family. So the graphic on this slide is trying to illustrate the potential risk profiles that can emerge from a comprehensive assessment to try to help determine the response. So for example, in the top left-hand quadrant, you might have families who are deemed high need and low risk. So the high need can manifest in a parent who is diagnosed with a severe substance use disorder, but the family is identified as low risk because perhaps there are protective capacities available to the family, and this includes a strong social support system, potentially including a sponsor from AA that has been working with the parent for an extended period of time. And the case may involve older versus younger children. Another example is on the top right-hand corner. You have a risk profile, again involving high need and high risk. So the high need can manifest in a parent who is diagnosed with a severe substance use disorder, but the family has been tagged as high risk, perhaps because there's a lack of protective capacities. It involves a young child, perhaps a baby, and the family is socially isolated. There are really no protective capacities available to the mother to help care for this child because her substance use is so severe, she really can't do it herself. Okay. The second question that we're going to pose to you is, why is Weight Watchers the most successful weight loss program? A, the food is delicious. B, the high level of support provided to clients. C, the commercials are fabulous. And D, Marie Osmond and Jordan Sparks. You guys are so smart. And the correct answer is the high level of support provided to clients. So this truly is not a plug for Weight Watchers. I just thought it was a fun way to transition into our next topic. The idea or the need to really engage parents into substance abuse treatment. So here's a referral. Let me know when you get into treatment. They'll get into treatment if they really want it. Don't work harder than the client. Call me Tuesday. So these are all the different quotes that we've heard from psychs when we talk about the role of child welfare in engaging parents into substance use treatment. Studies have shown time and time again that early access to treatment, early intervention is critical to a positive outcome. So peer mentor models have been proven effective in engaging. I'm sorry, I lost my train of thought. So peer mentor models have been proven effective in engaging families. So I think those of you in the audience who come from child welfare are very familiar with this model. They're often referred to as a parent-partner model. They've also been used for specifically in working with families affected by substance use disorders, and they're often referred to as the recovery support specialist, as well as a whole host of other titles that you see laid out on this table. So what this table does is it just shows you what the three primary components of peer mentor models are. Number one, they serve as a mentor and advocate. They really help guide the family through the child welfare system. And I think one of the reasons they're so great at this is because they have the experiential knowledge of experiencing the child welfare system. So they can really serve as an advocate, advisor, and guide to the family. How that looks different for the recovery support specialist is that their experiential knowledge often also includes that they're in recovery themselves. So again, they're able to guide the parent in that component of the case plan. Peer mentors also serve as a liaison. Peer mentors also serve as a liaison. They really improve collaboration between the systems. And they really serve as linkages between systems and really work to get families connected to treatment, particularly substance abuse treatment services. So a system of early identification and intervention can only be accomplished through collaborative practice. So the rest of this presentation is going to go through some of the how-tos of collaborative practice. So we're nearing the close of our presentation, so I'd like to just again encourage you to go ahead and submit your questions to us. Okay, the last question I'm going to pose to you today is, who potentially are your missing partners? Mental health, child welfare / dependency court, law enforcement, substance use treatment, or other? Okay, so the reality is there is no right answer. We really pose this question to help you think through potentially who are your missing partners in trying to work with families affected by substance use disorders. You know what I just realized? It looks like the substance use system was not included as one of the potential responses. So if I did my job, and if this presentation has convinced you, what I was really hoping would happen is that the majority of you would select substance use treatment with the understanding that really the only way to try to work with these families and improve outcomes, get them into treatment and so forth, is if you partner with substance use treatment. Okay, so you saw this slide early in the presentation, and again, I just wanted to remind you of the importance of shared outcomes across systems. So I wanted to take some time today to share a little bit from the field in terms of what different sites are doing in regards to the early intervention and identification of substance use disorders. We have worked with sites who are screening at multiple points in the child welfare case instead of only during the investigative or emergency response phase. We've worked with sites who have fully implemented a system of early identification and treatment access. And what does that look like? It generally entails screening done by the child welfare worker during the emergency response. The results of the screen in combination with the observations, etc., made by the investigating social worker really helps determine whether a more in-depth substance use assessment is necessary. And if necessary, the parent is then referred to a treatment professional agency, etc., to conduct that assessment. And this has really resulted in enhanced identification of families with substance use and access to and engagement in treatment. I think another key point in the system of early identification and treatment access is the idea of warm handoff. So when a family is referred to a service, and when a family perhaps is in this particular process, when the family is referred for an assessment, and following the assessment, if treatment is necessary, and the family is referred to treatment, the idea is that the warm handoff really improves those engagement rates. And so some of that can be accomplished with the use of the recovery support specialist. So what we've seen sites do with the recovery support specialist is to sometimes co-locate. So you might have a treatment professional co-located in the child welfare office. Or in some situations, you might even have the recovery support specialist or substance abuse specialist accompany the investigating social worker out there on some of the allegations to help make the necessary assessment of the substance abuse issues. So what's interesting, we learned recently that we have a site who, as part of their early intervention system, moved away from the use of a standardized screening tool and instead is using a set of guidance questions for the child welfare screen. And the reason they did that is because it really was an issue with the fit of the tool for the needs. I think there was a lot of implementation issues that site was experiencing. What we're also seeing more and more often is that many sites who have decided to implement some sort of comprehensive or universal screen for substance use disorders have now expanded that a little bit, and instead of screening solely for substance use, are also trying to screen for multiple needs such as domestic violence, mental health, etc. So I like to call that screening for more global and comprehensive needs, particularly as so many of our families are affected by a host of issues and factors. So I'm not going to go through the next two set of slides, but I thought that these questions to consider in the development of a screening and assessment protocol might be helpful as you think through potentially what you can implement in response to working with families affected by substance use disorders. So you saw this SAFER publication much earlier in the presentation. I've chosen to highlight it again at this particular point in the presentation because in addition to providing examples of screening and assessment tools, it really provides a how-to guide to collaborative practice. And you see included here on this slide are the premises that the SAFER model of collaborative development is based on. So the SAFER model of collaborative development includes guidance on developing your collaborative structure. And you can see on the slide that the collaborative structure can involve the development of an oversight committee, the steering committee, and the subcommittee. And again, sometimes it's important to kind of organize who will be doing what in the collaborative piece to really make sure that the collaboration is true and results in the development of policies, practices, and so forth to really impact families affected by substance use disorders. SAFER also includes steps to developing a collaborative. So what I'm really hoping to convey with this slide is if you go to the SAFER publication, you'll see that it's very much geared to in a how-to sense. If you are ready to move forward in developing your collaborative to better work with families affected by substance use disorders, this is how you do it. It's broken down step by step. We even include samples, sample communication that you can use between the systems. The next set of slides describes a collaborative approach to the opioids issue. So because the opioids issue is so prevalent, I think, throughout the country, the National Center, I think at this point, maybe about 2 years ago, convened a national work group composed of about 40 professionals from child welfare, substance abuse treatment, medication-assisted treatment, and various medical providers to really develop guidance on a collaborative approach to the treatment of pregnant women with opioid use disorders. And that collaborative approach really seeks to ensure that, number one, women with opioid use are identified during pregnancy. These women are engaged into prenatal care, medical care, substance use treatment, and other needed services, and the development of a case plan or plan of safe care for the mother and the baby. And we think that these three approaches will really reduce the number of crises at birth for women, babies, and the systems. So as part of our work, the National Center has also conducted a case study of the CHARM Collaborative located in Burlington, Vermont. So the primary goal of this particular collaborative is to improve the health and safety outcomes of babies born to women with history of opioid dependence. You'll see they have various service partners involved in their collaborative. I think for me, the two things that really stand out in terms of what this CHARM Collaborative does is the idea of early intervention. I can't recall at this point if it's a statewide policy or if it's centered to the Burlington work, but that child welfare is able to open a case when necessary during the pregnancy, or more specifically 30 days prior to the birth. So that really speaks to the importance of early intervention, and that potentially may open many resources to women and their families. Something else that really jumps out from this group is a high level of support and parent engagement provided to parents. So there's a very intense level of support provided to women during pregnancy, delivery, and postpartum. In some cases, when it's determined that the the baby born with NAS is in need of treatment with medication-based treatment, in some instances, the parent is then trained to administer those medications to the baby following hospital discharge. And of course, a high level of support and training goes along with that training. Okay, so we're at the end of the presentation, and we're going to get to a lot of the resources that are available to you through our National Center website. Before we go through that, I again highly encourage you to submit some questions to us. Okay, the first set of resources really focus on collaborative practice. So again, there's SAFER. We have the collaborative practice model, which provides examples of collaborative practice across the country. And I've also included some publications on understanding data systems across the systems. This slide of resources represents what we currently have available for the opioid-related issues. We have facilitated a webinar composed of a series of webinars composed of 3 different webinars, and you see the links made available to you. If you click on those links, it'll take you directly to the webinar. We have developed a resource list on medication-assisted treatment for opioid dependency. I don't think we have that on the website, but feel free to email us, and then we'll go ahead and send that out to you. I referenced the collaborative guidance document that we have been developing. That is not yet ready for dissemination, but what is available is the case study on the CHARM Collaborative. So again, you can email us, and we'll go ahead and send that to you. We have various staff development or training resources available. So one of those is our National Center online tutorials. We have one each geared for child welfare, substance abuse treatment, and court professionals. Depending on the discipline, either CEUs or CLEs are available. We think these tools are really great because they're web-based. There's no cost associated with taking the training, and it's really self-paced. Somebody can take the training, take a break, and come back maybe weeks later to complete the training. And we think that the information that we provide in there is really great and really comprehensive. We also have our child welfare training toolkit. So this toolkit was really developed for a trainer to train others, potentially in a trainer of the trainer model. So it's composed of 6 modules, each containing a trainer script, PowerPoint presentations, handouts, and case vignettes. And again, these are available on our website. We also have some materials on how to better or perhaps start the conversation on engaging your substance abuse treatment partners. So we facilitated a webinar on the issue, so go ahead and email us and we'll send that to you as well. During today's presentation, we spoke a lot about family-centered treatment. So this slide kind of shows the continuum of family-centered treatment and what that might look like. We have developed a publication on it, and the link on this slide will take you directly to that publication. Okay, and we have a whole host of other resources that are described in our catalog. We can send that catalog to you as well when we send out the PowerPoint today, and you can also access all of our resources on our website. So this is my contact information. Feel free to email me or visit our website for any questions or follow-up technical assistance. Okay, maybe we have a shy group today. That's okay. My understanding is that you just came from another phone call, and I know that I threw lots of information at you, so it might take some time to digest. So again, feel free to reach out to us with any follow-up questions and potentially how we can help you in working with families affected by substance use disorders. So with that, we're going to go ahead and close out the webinar, and we thank you for your time and attention.